We shall now go on to our last speaker, Dr. Pavitra Patel. Nice of you to have been patient. It's just a chance that somebody becomes the last speaker. And a very young cataract refractive surgeon from Sai Deep Eye Clinic and Crystal Vision Laser Center, Mumbai. And she is going to show a great video for us. On to you, Dr. Pavitra.
Thank you, ma'am. Thank you for giving me this opportunity to present my video on this platform. Also, I would like to thank all the speakers and the experts present here for all their teaching tips and tricks for young surgeons like us. So I'll just start my video. So this case was of a patient having grade 2, grade 3 nuclear cataract who was planned for a toric IOL implantation. And here you see I had difficulty in chopping and only got several incomplete chops. Also, there was difficulty in free rotation of the nucleus, but after multiple attempts, I could rotate the nucleus.
Video is not moving.
Video is not moving.
Is it moving now?
No. Dr. Anand, can her video be shown from our end?
Yeah, no problem.
You stop sharing
Yes,
your screen, Pavitra. Dr. Anand, you are sharing her video from your end?
Yes, ma'am.
Yes. Okay. Yeah, you could start. Start, Pavitra.
Yeah. So after multiple attempts, I could rotate the nucleus, and also here, as you see, the hold of the nucleus was not very good. There were multiple attempts tried for chopping of the nucleus. Now here, so here when I tried injecting the visco, I noted that the pupil became irregular and it peaked towards the main port. And I realized that this was because of the vitreous strand prolapsing into the main wound. And I used a repositor to reposit the vitreous strand. And then I realized that there was a zonular dialysis. So for the ease of the placement of the capsular hooks, I shifted myself to superotemporal region. I placed 2 capsular hooks initially to begin with. And then once the capsular hooks was placed, the back got stabilized and the nuclear fragmentation became easy. One by one, the nuclear fragments were chopped and emulsified. This was all done by keeping the IOP to as low as 30 millimeters of mercury. It was difficult, but somehow I managed to remove the nuclear pieces. Now again here, as we are seeing, the pupil is getting constricted. So then I thought of placing 2 more hooks for better visualization. And after placing the 2 hooks, the remaining nucleus and the epinuclear sheet was removed. Then the bimanual irrigation aspiration was done for the removal of the cortical matter. Now, once the cortex was almost removed, I inserted a capsular tension ring for more bags for the bag stability. The CTR was placed from the opposite area of the zonular dehiscence, which was near the main wound. And this was done with the help of McPherson's forceps in the one hand, and Sensky's hook was used to guide the CTR into the bag. And I removed the remaining cortical matter. The main incision was, the vitrectomy was done for that vitreous stand. Then the main incision was increased from 2.2 to 2.8, following which a non-toric 3-piece monofocal IOL was safely implanted into the bag. And then the capsular hooks were removed, wounds were hydrated, and single suture was placed at the main wound, which was removed after 3 weeks post-operatively. Thank you.
Thank you. Thank you, Dr. Pavitra. We always say it's keep the best for the last. And that was a wonderful video you showed, though very young. It had all the skills of a very experienced surgeon. I would want my expert panel to comment on some of these things. Role of capsular hook versus iris hooks. And I think the CTR placement being delayed seemed to make sense in this case, because she had kept enough capsular hooks to support the whole bag and go ahead with the surgery and then place the CTR. And the other comment I wanted from the expert panel, Dr. Madhukar, I believe Dr. Rohit Om Prakash is also there, and Dr. Saurabh. What would be your comment for placing the IOL, 3-piece IOL in the bag versus 3-piece IOL in the sulcus with optic capture? These are the two questions I have to ask.
As far as the first part is concerned, the first part was, would you prefer a capsular hook or an iris hook? Well, the answer is simple, that capsular hooks, if available, should be the only option. If they are not available, then obviously iris hooks can be tried, because these capsular hooks, they go right up to the equator and they provide an anterior-posterior support. Whereas these are the iris hooks can, they can get dislodged also. The second question was, as far as the timing of CTR is concerned, this we have already discussed. The only indication for CTR when it should be delayed is when it happens to be with the use of capsular hooks. What does capsular hook do? It helps us to delay the insertion of CTR. But CTR, even if when you are using capsular hooks, what are the indications wherein CTR should be used early on, when we find that the nucleus is soft? Because if the nucleus is soft, what happens is that when you are aspirating, because of the less bulky nature of the nucleus, the area between the capsular hooks can be aspirated by the phaco tip. So if the nucleus is soft, then in those cases, CTR should be implanted early on. The last part of the question was, in these cases, if we have to, what is the advantage of doing an IOL capture or putting a multi-piece IOL in the bag? Well, yes. If we do an optic capture in a small bit of rhexis, in a small bit of zonular dehiscence, it helps. It's a dual effect. It helps in stabilizing the bag. It doesn't let the bag get decentered. Well, if you are already used a CTR, and if the zonular dehiscence is less than 90 degrees, in those cases, a 3-piece IOL directed in the direction of zonular dehiscence also helps. So it's a choice, whatever you want to use.
Dr. Saurabh, you have anything to add? Dr. Madhukar? I think this is the last video we have seen. So
yeah, I think wonderful video. I think most of the technical aspects Dr. Om Prakash sir has rightly pointed out. But what I would like to tell for young surgeons, because this is something to do with what we are thinking during the surgery. I think during any ophthalmic surgery, when we are at a certain point desperate to do a particular step, we should know that we are doing something wrong. because most of the ophthalmic surgeries, there are steps and we have to follow those steps. So when we are desperate, just take a break, just calm yourself down and then think how you are going to proceed, because most of these situations arise because of desperate attempts. So I think if we can just try to think as a third person in that situation, that helps really. So I think that's just I wanted to tell about this situation.
Yeah, I think it was managed very well, and that was the right thing to do. And Rohit commented on most of the issues. Thank you very much.
Dr. Ramurthy, are you there? I don't see him there. Anyway, I think it's truly been a very nice learning webinar with very great expert panel and so much of energy from all of you right till the end. And of course, I'm sure all of us realized we saw a good variety of cases, different scenarios, different settings. Of course, cataract has to be a sort of a platform where there is some kind of an overlap, but there was much learning from the discussions. My thanks to my co-moderator, Dr. Satyajit, and my very strong ARC team. Our thanks are due to the AIOS admin led by Mr. Kripal, Dr. Anand Sethi and his webinar team. And I owe our thanks to Sai and Manjula from Numerotech, who have also been our backbone. And finally, thanks majorly to Entode for being constant sponsors for all our ARC activities. And last but not the least, if we stand where we stand today, it's because of the attendance of our attendees, and which eggs us on to do better and better each time. And thank you very much, all of you.